Acute pain is I call this the good pain because it's alerting you that you need to seek care. Now, chronic pain doesn't have the same role. It's not alerting you that something is wrong because that thing that started the pain already healed, and now you are left with the memory of pain.
There are over 300 million people living in the United States, and of those, an estimated 15 million people live with chronic pain right now. Our guest today is an award-winning pain specialist with decades of experience helping patients with chronic pain achieve a better quality of life. Dr. Andrea Furlan is a specialist in physical medicine and rehabilitation, an associate professor in the Department of Medicine at the University of Toronto, and a staff physician and senior scientist at the Toronto Rehabilitation Institute. In her new book, 8 Steps to Conquer Chronic Pain, A Doctor's Guide to Lifelong Relief, Dr. Furlan shares science-backed solutions to beat pain that she's seen work in her own practice. I'm really happy to have her here with us today because chronic pain affects so many lives, including mine. So for any of you listeners out there suffering in silence or who love people who deal with chronic pain themselves, I hope today's episode provides insights that offer a real reason for optimism. Welcome, Dr. Andrea Furlan, to the show.
Thank you so much. First of all, thank you for inviting me to be here and talk to your guests.
So, Dr. Furlan, tell us how you became interested in pain management in the first place, because I would imagine it would be a very difficult area of medicine because so much of it we don't see.
Yes. I'll tell you my story. It's back 30-something years ago. So actually, I experienced a lot of pain during my teenage years. I had very severe menstrual cramps. And they were debilitating, and they were, I had to miss school, and it was embarrassing that I had to be picked up by my mom. I was in high school, and she had to pick me up in school to bring me home. And a lot of medicines didn't work. I was applying hot packs and anti-inflammatories, but they ruined my stomach. So I had a lot of experience with pain, and I found pain is so debilitating. It can interfere with your plans, interfere with your life, and you never know how to plan the next day if you're going to be in pain or not. And then I knew I wanted to be a doctor. It seems that my family says that I said I wanted to be a doctor since I was 4 years of age. So when I went to medical school, I didn't know that there was such a thing as a pain specialist. So I came across physiatry. Physiatry is physical medicine and rehab. So that's what I chose. My specialty is physiatry. And when I was choosing which specialty, I came across acupuncture. And I remember I was in that, I think, last year of medical school, and I had to choose which specialty I was going to do. And I had admitted a patient in the general internal medicine ward. She was admitted because she had pain all over her body. Nobody knew what she had, and I admitted her for investigations, and we tested her inside out, everything. Nothing showed that could explain her pain. And then someone asked a consult for physiatry, and this physiatrist is a Chinese doctor. I did my medicine in residency in Brazil. So he came and he stuck a lot of needles on her. And suddenly she was walking, and we discharged her the next day. And I said, what is this? Is this voodoo medicine? What is this? So he was explaining to me, no, I did acupuncture. And actually, there's a lot of science behind this, and we are just helping her body to release her natural opioids. I said, "Oh, wow, that's exciting!" So that's how I chose physiatry, because he was a physiatrist. So in physiatry, I dedicated all of my years and my research for pain, because I always wanted to help people with pain. But then I came to Canada. And here I was, when I started practicing here, there was this huge opioid crisis that you probably heard. We are living in the middle of a opioid crisis for the last 30 years. And everybody was prescribing opioids. And, at that time, everybody was prescribing opioids for chronic pain. And I was scratching my head and say, listen, I know about acupuncture. I am an acupuncturist. So after that experience, I was trained to become an acupuncturist. I know exercise works. I know changing diet works. I know a good sleep thing works. Why you guys here in North America? I came from Brazil and we focus a lot on lifestyle medicine. And here everybody prescribing opioids, opioids, opioids. So that's my story with the chronic pain. And so I do have 30 years of experience helping people. And because I'm also a scientist, I I was the leader of the Canadian opioid guidelines, so telling physicians how to prescribe opioids and how not to prescribe opioids because they have a part to play, but not like for every single kind of chronic pain.
I would like to talk about opioids because, of course, when we talk about relieving pain, people right away think of either non-steroidal anti-inflammatory drugs like ibuprofen, or they think of opiates. That's pretty much all they think of, right? Those two sides. Can you talk first about the history of how doctors have approached pain? Because it's changed a lot because of opioids. And their ideas about how much pain a patient should endure.
Of course, yes. So I think God invented opioids because we can find them in plants, right? So opioids, morphine you find in poppy seeds, and codeine you find in poppy seeds. So they come in nature. So they are godsend. They are wonderful. They are the best painkillers that we have and we know for humankind. But they have a place, which is, if someone had a fracture, an acute pain, going through surgery, or they are, in a combat, in war. And I see your cat there.
Yes. He visits every time. I have a blanket on my knees just for him.
So, they are amazing for acute pain or cancer pain, the end of life pain, when we need to provide comfort to people, or for surgical, peri-surgical problems. The thing is, there was a push by advertising and propaganda, and a lot of people were saying, there are so many people with chronic pain, like low back pain, neck pain, fibromyalgia, all those muscle pains, arthritis. Why are we leaving them suffering if we have these potent painkillers? Why should they suffer? And if the rate of addiction is so low and there is no problem. So the early research that was done with addiction to opioids and opioid dependence was really a weak studies, because they looked at a small sample of people, put them on opioids, and maybe nobody developed addiction. But of course, when you start putting thousands, millions of people on opioids, the rate of people who will become dependent is much higher, because you are spreading to everybody. And that's when the problem started, because if you start offering to a lot of people opioids are going to help their pain initially, but later is not going to help anymore, because these people develop tolerance to the effects of opioid. And not only this, but opioids also help with emotional pain, because they numb those feelings of sadness, depression. They give euphoria. So you feel a little happy. You feel that your problems are being, it's the same thing with cannabis. Cannabis is the same thing. You're kind of masking the emotional pain. So you're not treating those emotional pains, traumas, psychological problems that are real, and they may aggravate pain. So you're kind of masking them, not treating them, giving these opioids. What happens is you need to start giving higher and higher dose, because the body develops tolerance. Tolerance means you need a higher dose to achieve the same effect. And then you create a problem, because you start giving higher doses. The person that is taking that higher dose of opioids, they kind of feel normal, because they have been adapted to the higher dose, right? And when if they miss a dose or they skip a dose, they feel horrible because they have withdrawals. So then they think that they need this medication for the rest of their life, but actually you're treating the withdrawals. Every time that they take the next dose, they're just masking the withdrawals, because if they don't take it, they feel horrible. So you kind of create a vicious cycle there.
I was told, I remember this was maybe 20 years ago, that if I took opioids, I had certain knee surgery, that if I was in pain and I took them, I wouldn't get addicted. I didn't think that made sense, but that was sort of the general idea. Like if you
Yeah,
need
yeah,
them, you won't get
yeah,
addicted. But that's not
yeah.
true, right?
Exactly. No, that was what
Okay.
we knew at that time. Yeah, we didn't have a better answer at that time. And a lot of research has been done. So having pain actually does not protect you from becoming addicted. But for sure, everybody who uses opioids every day, for sure, 100% will become physically dependent, which is different from addiction. Physical dependence means your body will create that dependence. And it's funny that our body develops dependence not only to opioids, but to benzodiazepines, which are those sleeping pills, to hormones. So if a person is taking thyroid hormones and they skip one day, they will have withdrawals, they will have symptoms. So dependence is a physical dependence, which is your body will ask for that medicine and you feel horrible, all the withdrawal symptoms, alcohol, tobacco, cannabis, they all develop physical dependence. Now, addiction is different, because addiction is a disease that the person loses control over how they're using. So
Ah,
because of the
okay.
dependency is a very strong physical feeling. So a person that becomes addicted, they crave a lot. They want to get that medication or that substance.
If physical dependence is physical, addiction is when emotionally you can't deal with the withdrawals, and so you continue on the
But
drug even when you don't need it.
you need to have the physical dependence
Hmm.
to develop addiction, because what the person will feel is they for them to feel normal, they don't want to feel the withdrawals, like they can't tolerate the withdrawals. It's so for some people it's really, really severe. The withdrawals can be quite severe, especially for opioids. They think they're going to die. So what happens is you need to have that physical dependence, and then you have that psychological aspect. I don't want to call it physical dependence and psychological dependence, because they are basically intertwined. It both are physical dependence, but when the person starts losing control, they crave, and they know it's harming them, it's harming their relationships, it's harming their job, they can't perform well, they know, but they can't stop. So they need help. So there is help for people who are dependent on any substance, basically. And they need treatment for addiction. And there are physicians who specialize in addictions medicine. So they are there to help.
Okay, so I think I understand the difference between physical dependence and addiction. It sounds like if people are dependent long enough, they will become addicted, right? Is that everybody?
It's a matter of time, because you may be physically dependent. Like if you take opioids every day for 2 weeks, your body is going to become physically dependent, even 2 weeks. Okay. Which means that if you try to stop cold turkey, your body are going, you're going to notice some withdrawals. But then those withdrawals may be mild and you may tolerate them and stop. Now, if you take opioids for a long time, especially in higher doses, and you don't have a good reason to stop them, you're taking them forever and ever and ever, and now you start taking, using, you know stealing some money to buy more opioids because you can't tolerate the withdrawals, or you try to stop but you can't, and you start using, the doctor gives you, let's say, 30 tablets for 30 days, and then you use all 30 tablets in 2 days, so you lose control how much you're using. That is addiction. And a lot of people develop this transition from physical dependence to addiction. It's not like one day you become addicted. It's a slow transition, right? So you start seeing some symptoms here and there and there. So when we are prescribing opioids to a patient, we need to be very careful. We're always monitoring. Am I seeing some signs that this person is going from just physical dependence to a opioid use disorder? Because that line is very fine and it's gradual.
I have a friend, Dr. Travis Reeder. He wrote a book called In Pain, about his opioid addiction after a motorcycle
Oh,
accident.
no.
And he had such trouble finding help getting off his medication,
Yeah, yeah.
even though he worked at Johns Hopkins.
Wow.
He could not find anybody. It's shocking. So it's a very good book. I highly recommend it. Something you mentioned was the link between emotional pain and physical pain.
Yeah, yeah.
Can you talk about that? Elaborate a little more. How are they linked?
Yes, for sure. So f- let me back up a little bit. Can I explain to you what is pain first, so then it will be easier for me? Yeah.
And the difference between chronic and acute would be great too.
Yeah. So
Yes.
let me explain to you, because then I'll come to the physical and emotional part of pain. So pain is, we are born with pain because it is our alarm system of our body. You probably heard that there is a very rare disease. It's called congenital insensitivity to pain. Congenital because they are born with this defect and they can't feel pain. And so just kids, usually they can't live, beyond teenage years or their 20s because they have a lot of injuries, they don't feel, and so the pain is not there to protect them. So pain is our alarm system of our body. We need pain to survive, basically. But that is acute pain, because acute pain is like I like to use the analogy of the alarm of a house. So you have a house, you install the alarm because you want the alarm to make a lot of noise if there is a burglar, a smoke, fire, or a flood in your basement, right? So you want it to make noise. So you install the alarm system to protect your house. That's acute pain. We have sensors in our skin, we have sensors in our muscles, tendons, in our viscera, our heart, to protect us if something is abnormal. Now, imagine that this alarm system that you installed in your house is malfunctioning. So there's no fire, but the alarm is making noise. You're not going to call the fire truck, police, or ambulance, right? You're going to call the alarm company. That's chronic pain. So chronic pain, when acute pain transitions from acute to chronic, it's because the original injury, like the physical pain that the person had, is already healed, and all injuries heal. Even a disc herniation, it heals. A disc bulge. People they come to me and they say, I have this low back pain. And they show me an MRI from 5 years ago that had a disc herniation. I said, that's healed. That's gone. You don't have that anymore. Oh, no, no, but I still have the pain. I said, yes, but because your pain transitioned from acute to chronic. So acute to chronic means the chronic pain is when the alarm system of the house is malfunctioning. It's making noise. It's making noise all the time. It's the volume is up, Alexander. So it's not just it's making noise, but it's waking up the whole neighborhood. And these patients, they come to me. They're very, very stigmatized, very frustrated because they have nothing else to show. Most of the time, they say, Doctor, I still feel pain. They are 10 years, 15, 20 years in pain. They still have pain. And then the doctors tell them, but I investigated you. There's nothing wrong with you. Everything's right. You must be imagining this. But they know it's real. And I tell them, I know it's real because it's almost like living in a house where the alarm system is going off all the time. It's very loud and only you hear. And you call everybody, they come and say, no, no, you must be crazy because we are not hearing the noise. So these people are pushed from one specialist to another one. They end up sometimes having surgery, many injections, thousands of investigations, x-rays, blood tests, MRIs, and they have this pain for many years. So at this point, they have not only the malfunctioning of the pain system, which is a real pain, which is the pain they're not imagining, the pain system. We now know with a lot of research, we know which parts of the pain system can have been malfunctioning, but they also have all of this emotional baggage with them because they have been, you know, disbelieved, they have been stigmatized like drug seekers, opioid seekers, because they want some comfort, they want some relief. And they go to emergency department and they are tired, they don't sleep well, they are depressed, they are anxious, they probably lost their job, their dreams. Many of them lost their relationships, the family abandonment, they are alone. And so I call that the emotional pain, which is all these consequences of having chronic pain, because we now know the emotional centers in our brain, they regulate a lot the intensity of pain that we feel. So if you're happy, if you're, there's a lot of research, very interesting research. Believe me, very interesting. Like they bring people to laboratory, give them some happy figures and watch a happy movie and then provoke pain. And then other people, they will see sad, depressing scenes or movies and they will provoke pain.
Right.
The people who saw the sad visuals and sad movies, they feel more pain with exactly the same painful impulse. They feel more intense. So we know if you are depressed, you're not sleeping well, you are alone, you are abandoned by your family, you lost your dreams, you will feel more pain.
Will
So
you
we need to,
feel more pain, or
yeah,
just,
with the
sorry to put,
same stimulus, with the same
okay,
stimulus.
if you have a pain already and you become emotionally sad because of all the stress
Yeah.
around that,
Yeah.
I can understand why it gets more severe.
Yeah.
Your whole body
Yeah.
is in more distress. But if you're in pain, if you see something emotional that affects you negatively, can you develop pain, or does it just
No.
exacerbate what's already
No, it
there?
just exacerbates what you have. Yeah.
Okay. Okay.
Although
There's
what you ask is it might be true, because we also know that our body express our emotions. Okay, we do have an example that I give in my book. I mentioned so many cases in my book. One example is a person that has stage fright, so they're afraid of speaking in public, and if they go on stage, they're going to have sweats in their hands, flushing, palpitations. That is an emotion that is being expressed in the body. It doesn't mean that they need to see a cardiologist because their heart, they have a heart problem. No, everybody knows that's an emotion, and emotions are expressed in the body. So sometimes the second chapter of my book, the step number 2 is look at your emotions, because sometimes your emotions by themselves without any injury are creating symptoms that may be abdominal pain, that nausea, headaches, aches in your body, and then they think there's something wrong with their stomach, but no, it's just the stress, is that fear, because again the pain system is connected with our emotions in our brain, so they go hand in hand.
And will somebody like that develop chronic pain? Because that sounds more
Yeah,
like acute pain.
could be both acute and
Mm-hmm.
chronic. Yeah.
Mm-hmm. Um, so thank you for giving that explanation of difference between chronic and acute, and the difference, and how emotions affect it. Do people who get the same stimulus of pain feel it differently?
Yeah.
And,
Oh
and,
yeah,
and maybe you just
this
answered that.
the research. Yeah, I can tell you a lot of things that make pain different, because there's a lot of research in laboratory, and in many parts of the world, it's fascinating to study this field, because they do a lot of interesting research with volunteers that come to the lab and they provoke pain, and they bring people with chronic pain and also study how they respond to acute pain. So there are a lot of things that can influence how much the volume of pain the person feels. So I mentioned one. So it's the sadness or happiness on that day. That's why sometimes we have good days and bad days. That's why I do have a lot of patients that they tell me that they went to on vacation 1 month in a place that was nice. Like I have patients that they tell me, I think it was the water that I was drinking in Greece, because I didn't feel the pain for the whole month. I said, no, it's the water is about the same. It's because you left your problems here in Toronto, and while you were in Greece, you forgot about your problems. So the emotional state of the person has a huge impact on how much they feel pain. Because when you are, again, the centers are connected in the brain. When you are enjoying your day, you are distracted, you are happy. It's almost like your brain is blocking anything that is unpleasant, saying, I don't want to hear about this. So it's going to block. And it's very interesting that the way that the brain blocks is by producing opioids. We have, this is the brain here. Let's say this is the brain, and we have the brain stem that is holding the brain. So in the brain stem, we have an inner pharmacy that produces opioids, endogenous opioids like endorphins, dynorphins, and enkephalins. They're super powerful. They also produce cannabinoids. It's similar to the THC, CBD that everybody wants to use these days for pain. And they also produce serotonin, which is the hormone against the neurotransmitter for mood that combats depression. So if your brain tells your brainstem, so the brain tells your brainstem, produces a lot of, it releases this, open the doors of the pharmacy, you'll be, not inundated. You cannot get addicted, although some people get addicted to their own endorphins by yeah, by running. They can get a high, the runner's high. They can get addicted to this, but most people probably not. They get inundated with those inner pharmacy that is open, and they don't feel pain, and it's so powerful. Now, you probably heard about fibromyalgia,
Yes.
which is pain all over the body. It's a disease of the pain system. People with fibromyalgia, they have one of the places that fibromyalgia affects the pain system is this inner pharmacy. Their inner pharmacy is kind of insufficient, sometimes cannot produce anything. So we can measure now, and we know, because you provoke pain in people with fibromyalgia, and there's release of nothing. They don't open anything in this inner pharmacy. um, Complex regional pain syndrome, it's CRPS, is another disease, is a very painful disease too, affects a lot of young women. They also have an inability to release these inner pharmacos in the brain stem. So we are starting to understand what's happening in the pain system with a lot of chronic pain conditions.
Hey, friends and listeners of the Switch for Good podcast. Yep, that's you. I have some really exciting news. Dotsie and I have started a Switch for Good podcast Facebook group. We created it so we can build a community of fans that will help us improve the show and deliver on the topics that you want to learn more about. So we want to hear what your favorite content is, what you want more of, and what you want less of. And if you like the length of the show, Dotsie and I are always talking about the length of the show, right, Dotsie?
Yes.
We want to tailor our show around the needs and desires of our incredible listeners, almost 500,000 of you. And it's really simple to join. Just go to our Switch for Good Facebook page. That's Switch, the number 4, and then Good. And then click on groups. And there we are, the Switch for Good podcast chat. You can post directly in the group, share ideas, talk to other listeners, and connect with like-minded folks. So go, run, join our Facebook group and tell us what you want. I have several questions now. Let me go step right off into what you just talked about. Do we have Can each of us improve our own inner pharmacy? And is that maybe what your book is about, improving your own inner pharmacy?
Yeah. Yes, we can. Yeah, my book is about this, because my book is about I use a biopsychosocial spiritual model in my book. So I talk about the biology of pain, but also the emotions, the social aspects of pain, because pain is affected by your environment, and you also interact with the environment. Yes, so in my book, I talk about all the things that we can do, and with a big focus on what the person can do for themselves, self-management. I think there's a lot of these strategies the person can do for themselves. So how do you increase your pain threshold? How do you increase your resilience to pain? How do you become more resistant to pain? We know there are in terms of medications, very little benefits. There are some that may help, especially if the person is depressed. We give some medications to increase serotonin, so that will help them to fight the pain. But The best evidence that we have to improve this inner pharmacy and activate this inner pharmacy comes to two interventions. Two. Can you guess what are the two?
Well, for me, I know what they are. They're exercise and diet for me, but I
Okay.
don't know if that is.
So diet, we don't. Diet might be pretty much. We don't have a lot of evidence for diet yet, but I include one of the steps of my book is about nutrition. But the two that we have a lot of research is exercise, absolutely, and mind body therapies. Okay,
Mm,
so meditation, mindfulness, relaxation of the mind, vagal nerve stimulation. So because when you can activate those areas that because the vagus nerve is the main nerve of the parasympathetic nerve system. So a person that is in chronic pain, they basically have the sympathetic. Are you familiar with those two concepts?
I
The
I
sympathetic.
am, but explain
You
to
want me to
our.
explain? Okay.
Yeah. Hmm.
So the sympathetic nerve system and the parasympathetic nerve system, they are autonomous nerve systems. They run in parallel to our brain and to our brainstem. They are kind of autonomous. They don't need a lot of or thinking to tell them what to do. The sympathetic nerve system is the fight, flight response. The parasympathetic is the rest and digest and heal response. So they are opposite. When you have one going up, you cannot have the other one. So imagine that you are walking you're hiking in a ravine, you're relaxed, you have your parasympathetic nerve system active, the other one goes down, and then suddenly you see a bear. A bear. So a bear in front of you. Here in Canada, we can see a bear if you want. Depending on where you go, you can see a bear. So you see a bear. So suddenly the parasympathetic will stop. The sympathetic will be totally activated, adrenaline everywhere. Run and save your life. Okay. So in people with chronic pain, they have this sympathetic nervous system is in alert all the time because they're always looking for danger. They're in pain. They're in pain all the time. So if you're in pain all the time, your brain is receiving, where's the danger? Where's the danger? Is it a bear? Is it a car coming? Because that's what the pain tells them. So they never have the parasympathetic active. It's kind of a retired. Um,
And that's
so we
very
need
stressful for somebody because of all the chemicals that are released when you are in the
it's
sympathetic state has really serious
extremely
long-term effects.
we can measure this with questionnaires. So when we use these questionnaires in a clinic, you see the high levels of in the questionnaires that measure anxiety, stress, PTSD, sleep quality is disrupted because like you are in hypervigilance all the time. So they don't sleep well, and then they are fatigued during the day because they're not sleeping well. So they are fatigued during the days, insomniacs in the night. They are tired, they can't concentrate. I don't even know if they will be able to read my book because they say, I can't read. I'm so tired. I'm so overwhelmed. And that's because of this overdrive of the sympathetic. So I teach them how they can activate the parasympathetic. And then we start giving them message that they are not in danger. Look, your body is not broken. Your MRI may look horrible, but my 92-year-old grandmother MRI is also horrible and she doesn't have any pain. So that doesn't mean anything. So once you start giving them messages of safety, your body is okay, you can move, you can do your exercise. Oh, but it hurts when I do exercise. I know. We're going to go very slow, very slow, because you need to activate that inner pharmacy. So you need to start moving. You need to start doing those mind body therapies because you need to lower this sympathetic drive and increase the parasympathetic. So those two, when you ask me about what are the things that we know best, I think all the 8 steps that I mentioned in my book are essential because they need to learn about. So the first step is basically learning what I just told you here. What is chronic pain? Understand that pain is real, that the pain system may be malfunctioning. The second step is what are your emotions? How your emotions are interacting with your pain, making it more intense, like increasing the volume. And then I talk about sleep and diet and exercises and modalities and the social environment around you. The last one will be your goals for your life, but the second last one is about medications. So I'm not against medication. I have a whole chapter in my book about medications, opioids, antidepressants, anticonvulsants, NSAIDs, muscle relaxants, but I leave those as a last resource because if we do all the first ones, we may not need medications.
Modality, what does that mean? Alternatives
So
from a
yeah,
practitioner?
modalities is yeah, acupuncture,
Mm.
massage,
Mhm.
spinal manipulations, TENS machine, anything that heat and cold, applying hot packs or cold, ice cold packs, all of those things because they, although you apply those things in the skin, they send messages to your brain and they activate those, centers of the brain that are deregulated. Sometimes they are like we know TENS machine, if you apply to the skin, actually it's not doing anything here, but it's sending electrical impulses to the brain, and those impulses will make your brain to release some endorphins and also will compete with the pain because while you are feeling the electrical shock sensations, your brain is occupied with that and it's almost like a close the gate, so the painful impulses don't come from the periphery. But TENS works better for acute pain, not so much for chronic pain.
You mentioned early on that a patient will come to you with an x-ray of their back or MRI saying, look, I've got something physically wrong and I still am in pain. And you say, well, it's not from that anymore.
Yep.
Do you not, would you, for this patient, for example, would you not look at the back at all and try
Yeah,
and
no, you
help
are.
the
Yeah, we
back?
will. Yeah, we will. So I explained that quickly. So what we do is we combine the symptoms that the person is telling me. Okay. So if the symptoms are, let's give the example of a disc herniation. Okay. They had a disc herniation in the lumbar spine, let's say 3 years ago, and they're still in pain. So when I look at the symptoms, when they tell me the story, so I ask them, tell me, how is your pain? If the pain is being caused by a disc herniation, that pain will have a very specific pattern. Very specific. It will be localized in that area that is innervated by that nerve. So they will say it's only on this side. It follows like we call this the dermatome. Dermatome is the area of the skin that represents that nerve root that is being compressed by that disc herniation.
Is it right there usually, or could it be in your foot if your back
No, it
hurts?
could be in the foot. So each
Mm.
nerve root, L3, L4, L1, L2, L3, L4, S1, each one of them have a specific area that they radiate pain. So the pain will be very localized, will be in that area, will be has some characteristics of neuropathic pain, and there will be some things that aggravate the pain and others that improve. So if they lie down with their legs up, I have a figure like this in one of my videos, and the pain will be improved. So I ask if all of this match with the disc herniation. I say, okay, now let's go to the bed and I will examine you and I do some maneuvers that will aggravate that disc herniation. And I say, okay, yes, I don't even need to look at the MRI. Just by looking at the what the patient tell me and what I find in the physical exam, I know it's plainly maybe it's a 3-year disc herniation, which is very rare because disc herniations they heal. Okay,
Mm.
but I know exactly. Then I go to the MRI just to confirm what I found in the history and physical exam and say, oh, yeah, I'm seeing the disc herniation exactly that matches what you were telling me in the history and what I found in the physical exam. Fine. So we will treat this as a disc herniation that is being caused by a problem there. And they don't have, maybe they have the pain system that is also malfunctioning. So they could have both, right? So now, if I see a lot of depression and a lot of anxiety related to this disc herniation, I know that they also are sensitizing this pain system and the pain system is malfunctioning. So we need to treat both pains. But when they come to me and they said, I had disc herniation 3 years ago, but their pain is not confined to that nerve root. That pain is now generalized, is in the arm, is in the other side, is in the neck, is in the back. I said, okay, that cannot be explained by one disc herniation in the L4 on the left side. And then I put them in the bed and examine them, do all those tests to provoke the disc herniation. They're all negative. And then I test their sensations in their body. And they, if I touch their skin here, they go like this. That's too much pain. We call this allodynia. And that's another sign that they're having sensitization in the brain. So then I say that MRI has nothing to do with your pain because you are spreading. The pain is spreading. The pain is outside of the boundaries of that disc herniation, has nothing to do. So this is not related to this. And this is so common. This is very common because if you MRI people, like if you get any person walking on the street and you MRI their spine, the older they are, the higher the chances that you're going to find something abnormal, but they don't have pain. So because MRI would just show an abnormal structure there. And I always tell the story of my grandmother. She was 92. She had a horrible, horrible neck, the most horrible osteoarthritis of the neck that I've seen my whole life. When I looked at that, I said, unbelievable. And then, Grandma, are you sure you never had any pain in your neck? She said, no, I had a little bit of pain in my lower back, but in the neck, no, never. So
So, what is the difference between the person? So, is it the pharmacy, the internal pharmacy, that went a little
not
wacky
only
when they
that,
had the acute pain, or because psychologically, what's going on with that
it's more than that.
patient
Yeah.
versus your grandmother, for example?
Yeah, I wish I could study the brain of my grandmother, but she passed away a few years ago. um, no, it's more than that. It's not just the inner pharmacy. So I can tell you the other thing. We There are many centers in our brain that the brainstem is only one of them. I gave you the example of the brainstem, but we have a lot of centers in the brain that are able to modulate pain. Okay, we know that children who had been exposed to adverse childhood experiences, ACEs, which is a traumatic, stressful event in the years that they were developing their brain. Because when a child is born, they don't have the emotional centers of the brain developed because you need to be exposed to emotions to develop those centers. So this is the prefrontal cortex, all this limbic system, all of them, you will adapt to the environment, but you need to be exposed to the environment in order to do this. So it takes about 18 to 21 years for your brain fully developed because you need those exposures. When you are developing the brain, if the child is exposed to adverse childhood experiences, which is a very stressful event in their childhood, this child that had been exposed, they will develop the brain differently. So when they become adults, those parts of the brain that should be there to help them fight pain, they're not there. And actually, they have the amygdala is one of this. We have two amygdalas, the right and left. And the amygdalas, they are hyperactive in children who had been exposed to stress during childhood because they grew up in such stress. The amygdala in the adults, when this person becomes an adult, the adult will be overactive. It's even bigger than what it should be in size. And the amygdala is the fear center. So now, if they have a little bit of pain, let's say we all have pain in our life, right? We all have pain here and there. Now, if this pain happens in a person that has the amygdala super active, they will respond with an exaggerated fear response. And that fear of pain, after that injury heals, is related to the perpetuation of the pain itself. So that's how the acute pain transitions from acute to chronic, because the injury heals, but the fear of pain continues. So your brain is unable to disconnect, or your brain doesn't know that that part is healed because it continues receiving information coming from the spinal cord, coming from the brainstem, coming from center saying, I think this person is still in pain. And so the vicious cycles continue. So actually, chronic pain, it's sad because the brain still feels pain, but you don't have a place to go and remove it. You can amputate that body part. You probably heard about phantom limb pain, which is you amputate a part and now the person has pain in that part that is missing. This happens with people who have been amputated their foot, hands, but also tooth extraction is an amputation. Mastectomy is a kind of amputation. People who had hysterectomy, that they remove the uterus, it's a kind of amputation. So they might be having phantom pain of the uterus that doesn't exist there anymore because the brain still did not disconnect from that area and is perpetuating the pain.
That's fascinating. So the body's still on alert all the time,
Yes.
like you mentioned.
Yeah.
This brings to mind a question. It feels like whenever we have pain, the immediate thought is, I need to get rid of it.
Yeah.
Is that a healthy attitude? And are different cultures do they have different attitudes towards pain, which means that
Yeah.
their citizens have a
Yeah.
lower threshold, maybe
Yeah.
lower incidence?
Yeah. So when we have acute pain, like just acute pain from nowhere, you didn't have that pain, and now today you have that pain. That's acute pain, and it's probably a good idea to want to eliminate that pain because probably there is a infection or something broken, or a fracture or an inflammation somewhere. So it's a good idea to want to eliminate that pain because acute pain has an important role to prevent that we do any danger to ourselves or that there is a disease that we need to get resolved. So acute pain is a good, I call this the good pain because it's alerting you that you need to seek care. Now, chronic pain doesn't have the same role. It's not alerting you that something is wrong because that thing that started the pain already healed, and now you are left with the memory of pain. It's funny, I'm using the word memory of pain because that's exactly what happens in the brain. The brain, the same way that we develop memories, if you learn to play piano or you were a sport person and you learn all of those tricks and you're good at what you did because you practice so many hours, you have all of those circuits are in your brain. And so you because you practice so much, you create a lot of synapses. We call this neuroplasticity. So it's easy for your brain to use that synapses again because it's so strong, that synapses. Synapses is when two neurons connect. If a person felt pain for 1 year, 10 years, 20 years, those synapses of pain are so strong, they develop that memory of pain. So what happens is to to break that pain signal now, it's going to require a lot of effort. And you need a lot of distraction from that pain. Okay, so you need to focus on other activities so then you can disconnect that synapses. But coming back to your question, how people feel differently. So if a person is feeling pain, whatever they say, it's what they're feeling. So if they say, I'm in a lot of pain, you have to believe in that because they are in a lot of pain. Now, different cultures and different families, and even within the same family, you have different people who feel pain differently. It's about how their brains were wired, how their resilience is able to um, inhibit pain. It has to do about what they believe the pain purpose is there. So in some cultures, pain is seen as a, a, a way of testing your character. And so they endure easier because they say, I'm being tested, so this is for my good. I know I'm becoming a better person because of this. So they still feel pain, but it's easier for them to endure and the suffering probably is less. Now, if the person doesn't have the same meaning, your brain needs to attach a meaning to this. Why am I suffering? I am the victim. I am, this pain that I'm having is someone else's fault. So let me tell you this. This is very important. I can get two patients in front of me with this exactly the same injury. Let's say the shoulder pain. Okay. One had a shoulder injury when they were playing soccer with the kids. They were happy and they just fell and ruptured the tendon and now it's hurting. The other one was at work, didn't like his work, hated his job, hated his boss, and then someone, didn't do what they were supposed to do and they sleep and fell. So now someone's fault that this person is. So this person will have a much difficult time to heal because the brain is just saying it's someone's fault. I'm the victim. They should not have done this to me. The other one will heal faster because they want to go back and play soccer with their kids again. So it's about your mindset, how you are. The brain is so powerful to control healing of the tissues, to decrease the pain level so then you can focus on the exercises. And it doesn't have to be dragging you unless if you have a reason to. So even the same person may have the same pain one day and the other day, and they feel differently just because the situation was different in both days. So yeah, pain is fascinating because so many things interfere with how much you are feeling pain and suffering from pain.
Mm. You specialized in low back pain. And as I mentioned in the intro, I have dealt with chronic pain, and it is in the form of low back pain for 40 years.
Oh wow.
But I manage it by doing yoga every other day, and then I'm
Mhm. Mhm.
fine.
Mhm.
I'm actually really good. And then some pain will come up, and I will, if I always have a stiffness,
Yeah.
except for right
Yeah.
after, but I don't really mind. Actually, I'm kind of grateful because otherwise, believe me, I never would have stretched a moment in my life. And now I'm very limber.
Yeah.
But I do feel like, why do I have this pain? I don't really know. If people ask me what it is, it feels like it's a muscle pain. And I've had MRIs and things, and I don't have a structural issue. So I've always thought that maybe what I'm doing is putting my stress in that area. But tell me
Yeah.
about low back pain because a lot of people
Yeah.
have it. And I've had it for 40 years. And I sometimes think, Alexandra, you really should go to someone and really get this solved. Is this something I can solve, or is it just something I deal with?
Yeah. Yeah, it's a hard question. Me too. I also have a chronic low back pain that comes and goes. Right now, I'm not feeling anything, but mine is not for 40 years. Mine started maybe 8 years ago with a very acute one, and I was debilitated for about 6 weeks, and I refused to do an MRI. I said, I don't want to do an MRI because I know this is going to get better and I don't want to see what it is because I know if I see, I am going to fixate in my head that that's the problem. And who knows if I'll be able to erase that picture from my memory. I didn't want to see unless, so I was monitoring my symptoms with an excellent physiotherapist. She examined me and she said, no, I didn't have anything serious that would suggest a cauda a compression of a nerve. So she said to me, okay, this will go away, Andrea. We don't know what it is, but this will go away. Rightly at 6 weeks, the pain started subsiding. And then, so what happens is now, once in a while, I have a flare of that pain. And because of that pain, I signed up for a gym. And that's why I go to the gym 2 or 3 times a week. Because again, like you, if it was not for that pain, I would not be going to the gym. I just go to the gym because I want to avoid that episode again. But the other day, I had a discussion with a person at work. It was a Friday morning. I had that, and it was so stressful. Guess what? Friday afternoon, flare of that pain. But then I said to my body, I said, I know this is just stress. I know you're trying to play me tricks. So I went to the floor here, started stretching, took an Advil, and I said, this is just the stress. This is just the stress. There's nothing wrong with me. Saturday morning, I woke up, no pain at all. So I'm not saying that this is true for everybody. Of course, there might be some serious things, and that's why it's always good to check with a physiotherapist, a chiropractor, a doctor, just to make sure that there is no compression of the nerves, there is no infection, no fracture. But most of the time, low back pain is exactly what you said. It's just muscle tension. It's just some arthritis that is developing there. you know, if it is too debilitating, sometimes I recommend people to have injections in the spine, the muscles, trigger points, or facet injections. But I rarely tell people to go to surgery, because only if surgery is totally necessary, not to treat the pain, but to treat a structural damage that is probably compressing a nerve. And if we don't do anything, the compression will get worse and worse and worse, and they may lose the sensitivity or the control of the muscles. Other than that, I would say what you are doing is perfect. Just, self-managing and not stress too much about it. When it comes a flare, treat the way you know. I'll treat the way I know. Going to the floor, doing my exercises, hot pack. Make sure that you know your emotions, what's going through your mind, and they will go away.
Thank you. I wasn't sure if I was avoiding something deeper and I should get to it and be more.
The warning signs for something serious I always teach is the NIFTY, and I talk about this in my book, NIFTI. So the for neck pain and for low back pain, if you have one of the NIFTs, then you need a serious intervention. So a neurological compression. So like if there is any nerve compression and you're losing sensibility, you're not feeling the skin well, or you're losing power in your legs or the arms. So neurological, then infection would be another one, because people can have an infection in the spine, especially in people who are immune suppressed, like they are on steroids or having chemotherapy, or if they use drugs, IV, because then bacteria can grow in the bones. So infection, but they will have fever and chills, and they will lose weight, and they will have pain at night. So infection. NIF, fracture. Then T is the trauma. So fracture, trauma if they hit. So sorry, for people who have osteoporosis, if osteoporosis, they can break the vertebra and they can have a fracture there and compress a nerve. So if they have osteoporosis, if they know they have, that's another risk factor. And the other one is an inflammatory disease of the spine. So for example, if they have ankylosing spondylitis, it's an inflammatory disease that can affect, there is specific medication like the biologics that treat ankylosing spondylitis. So those NIFTI is what they have to pay attention. If it's not one of the NIFTs, it's probably muscle, just arthritis, and self-management at home with exercises, relaxation, hot water, yoga. That's the best that you can do for your body.
Thank you. You mentioned that when your back hurt, you took an aspirin or ibuprofen, some kind of
Ibuprofen.
a non-steroidal anti-inflammatory.
Yeah.
Will you talk to that? Because I feel like we Americans, and maybe Canadians too, but certainly us in the Western world, we'll jump to that. People take those drugs like they don't mean anything. But I've been reading a book about inflammation, and
Yeah.
apparently, that should not be your
Yeah. Yeah.
first choice, and that is what most people take. That's what everyone just take
Yeah.
an aspirin.
Yeah.
So will you talk a little bit about that and how you
Yeah.
deal with that and the side effects of those drugs?
Absolutely. Yes. So the we are our culture, North American culture here. I live in Canada for 26 years, so I think I'm more Canadian than Brazilian now. It's a culture of quick fixes, fast food, and we want things done and done fast, and we can't wait, and I need to run, and I can't do things. But if we leave these resources for as the last resource, they should be the last resource, because they do have adverse effects. They do have complications. They should not be taken during pregnancy at all, NSAIDs. And even people who had any high blood pressure or cardiac issues should not be taking anti-inflammatories, because they can have serious effects on the, increasing blood pressure, causing a heart attack, a stroke. They need to be careful also if they have a stomach bleeding, ulcer, because they can bleed the stomach, the bowels can bleed, and it's a serious thing. You may need transfusion, you may need to be hospitalized, because they are very serious. I see a lot of people abusing NSAIDs, like taking 10, 20 tablets a day or more than that for pain. That's an abuse of these medications because they want to get moving with their life and they don't want to do other things. Or sometimes it's athletes who want to be pushing themselves, pushing, and they need a competition, they need win this and that, and they mask their pain because they need to be pushing themselves. So it's really sad, but I think a lifestyle modification is my way to go. We know that there are some nutrients, and I know you're big on nutrients and diet and nutrition, like omega 3s are, you know, right and center in my book. I talk about omega 3s as a anti-inflammatory component that is super important. I also talk about turmeric and curcumin. There is a little bit of research showing that they are anti-inflammatory. They will not solve the problem right away. The problem is the NSAIDs, you will see the effect right away. The
Hmm.
other one, the omega 3s and the turmeric, you need to build up, you need to create, this storage of them in your body. You need to incorporate in your diet basically on a uh, regularly for you to see the benefits, because you we want to, with omega 3s and turmeric, and what we want to do is reduce your chronic inflammation. They don't reduce so well the acute inflammation, and NSAIDs do that really well. The other thing that I also talk about is capsaicin, but they need to be careful because it can burn their skin. So yeah, I'm also a big proponent of trying things that are natural first, a hot pack or an ice pack. Ice is excellent as an anti-inflammatory. And before you go to those things, but I took that Advil before bed because I wanted to have a good night of sleep. But I did a
Of
lot of
course.
things before I took that Advil, the ibuprofen.
So tell me about headaches. I've been fortunate not to have headaches, just back pain, but I do know a lot of people who deal with them. And there's migraine headaches and there's other headaches. And what do you recommend for those? And what's the difference between the different headaches that people can get?
Well, that's a very loaded question because I could be talking here for 2 hours
We'll have to
about
have you
headache.
back just about headaches.
um, Me too. I never had any headache in my whole life. I'm like you. I don't know why. I'm the lucky one. I only had, I have foot pain, low back pain, and but never had any headache in my life. Um, so headaches. There are many different types of headache, as you mentioned. Migraine. Let's talk about migraine a little bit. Migraine is to the head very similar to fibromyalgia is for the body. It's a malfunctioning of the pain system. It's considered a primary chronic pain. So fibromyalgia is that pain all over the body because the pain system is deregulated. Migraine, there's nothing wrong with the head, but the person feels this horrible pain, pulsating. It's always the same pattern. They know that they're having a migraine because there is something before the pain starts that they know it's going. They feel and they know exactly what's going to happen. And after the headache period may last hours or a few days, they have that post headache, post migraine period, and then it cycles again, and then they have that period again. They have some days without migraines, and then they have an episode of migraine again. It's a primary chronic pain that affects, one side of the brain, the head, or both sides, and may have flashing in the head, in the eyes, or they are very sensitive to light or loud noise. So they like to be locked in a room and no noise, no light, and until the headache passes. So migraine in the last, because so many people suffer from migraine, it's so common. There's a lot of research for migraine, and the pharmaceutical industry actually developed a lot of treatments, and they tested in high quality randomized trials. So we do have evidence from high quality studies that there are a number of treatments that work for headaches, including injections of botulinum toxin, other injections like subcutaneous injections of CGRP, the triptans that are tablets that can abort a migraine attack. So we know these things work. So if they have migraines, I recommend them to see a good neurologist, and the neurologist will give them these options. And help them with these episodes.
But it's not a lifestyle thing. We can't solve the migraines with lifestyle?
It can solve completely. There might be some cases that they can be solved if they change. Diet is one of them. I know a lot of people that they cut some ingredients from their diet. Some people will be they swear by gluten. They say I eliminated gluten and then I never had migraines anymore. Other people, they will do something different. So I recommend people go to a neurologist to make sure that before you go to all of these treatments, there is exercise also. When they exercise when in the days that they don't have migraine. So if you're having migraine, go to the room, lock yourself until the migraine goes away. Don't do exercise because exercise may exacerbate. But on the days that you are migraine free, if you do exercise, that may space out your episodes of migraine. Yeah, so lifestyle, sleep is important, nutrition, exercise, relaxation, stress, all of those. But if they do all of this and they still have migraines, they might need one of those medications. Now, the other types of headaches, like tension headache, cervicogenic headache, cluster headaches, they are different. They are each one of them, they have a different pattern. Tension headache is very much related to stress. It's very much related to how it's almost like you feel here in your shoulders and the tension, and you know that it's related to some stressful events or you're overwhelmed, you're not sleeping well, too many things. That's tension headache. Cervicogenic headache is headache that is caused by problems in the neck and they radiate to the head. And cluster headache is a problem that it starts with the one side of the head and affecting sometimes the eye pain. And they have that, it's one of the worst headaches. They say it's one of the worst pains that exist to humankind. And it's seasonal. It affects, like you have a season, like spring. Every year you have those attacks of cluster headache, and then you spend months without it. And then the next year, the same season, you have those attacks of cluster headaches again.
But different people have them in different seasons. It's just that people, what you're saying is there tends to
Different
be a
seasons, yeah.
routine.
Yeah, cluster headache, different people. It's more common in the fall and spring, but some people have always in the summer, some people always have in the winter, but they come like in a season for months, a couple of months, and then they stop, and then next year they come again.
Wow. And what is the recommendation in terms of lifestyle for those other headaches? Is it the same as with migraine headaches? I mean, what I'm hearing from you is that overall health is important for
Yeah,
pain
we come back to the
and
same things.
stress. Yeah, yeah.
We come back to the same things, and the same things. Sleep for headaches. Sleep is very important because if you don't have a sleep routine, if you don't go to bed every day at the same time, I wake up at the same time, because if you sleep a little bit less, you may trigger headaches. If you sleep a little bit more, you may trigger headaches. If you have insomnia in the middle of the night, you may trigger headaches. So sleep is really important for headaches, but all the other ones as well.
Oh, great. Thank you. So it sounds like if people are in chronic pain or who know somebody is in chronic pain, that getting your book, 8 Steps to Conquer Chronic Pain, would be very important. I know it's coming out in April. Is that correct?
Yes,
Yes. Congratulations.
Thank
So
you.
how can people learn more about the book? Where can they get it, pre-order it, and also your
Yeah,
work?
right now
Because
they can pre-order. Yeah, they can pre-order from the major bookstores like Amazon or Barnes and Noble. In Canada, Indigo Chapter. They can pre-order, and as soon as the book shows up in the stores, they will receive their copy. And although the 8 steps cover a lot of things, there are people that will need, they will realize they need more, like a few steps. They don't need to do all 8 steps, but it's more like a journey for them. And the order of the steps that I put there starts with the knowledge about what is pain, emotion, lifestyle, and then modalities, medications. And then the last one is let's work on your goals. What do you want when you conquer your chronic pain?
thank you. It sounds like such a fascinating book that because so much of the population
Yeah.
deals with this, will be very, very successful and help a lot of people. I just wanted to mention to our audience that you also have a very interesting and full of videos, your YouTube
Yeah.
channel.
Yeah.
So talk to us about where people can find you to get actually a little daily dose of Dr. Andrea Furlan.
Yeah, so I am on YouTube. It's just my name, Dr. Andrea Furlan, and you find me there. I post one long video every week, and I try to post shorts almost every day. I'm trying. And I talk about these things that are, important for fibromyalgia, low back pain, arthritis, the treatments, including medications, modalities, mind, body, exercise. I have a lot of demonstration. I have a lot of videos that are my most popular videos are about diet, nutrition, or exercise. I'm doing some demonstrations of exercises.
Excellent. Thank you. Thank you so
You're
much
welcome.
for being on the podcast, Dr. Furlan.
Thank you so much for inviting me here.
Hey, folks. Okay, back by very popular demand is our plant-powered plate fridge magnet, which you are going to receive for free if you leave us a rating and a review on whatever platform you're listening to this podcast on. So here are the details. Just write your quick review. Does not need to be long, does not need to be a whole story. Just be honest and speak from the heart. Then take a quick screenshot of the review you wrote and email it to us at podcast@switch4good.org. That's podcast@switch4good.org. And include your mailing address so we can send you a power plate. We are doing this because the more reviews we garner, the higher we go in search results, which means more folks will learn about our podcast. So the power is in your hands. Leave us a review and zoom, your power plate arrives at your doorstep.
So thank you so much for tuning in today. If we helped you in any way, then click the subscribe button and let's keep hanging out together. We have so much more to share with you.
And if you need more information on actually making the switch for good, please visit us at switch4good.org for loads of info. And you can subscribe to our mailing list where you will receive all sorts of super cool gifts, discount codes to our very fave dairy-free products, and a lifetime of powerful health tips.
So join us on the journey to Switch for Good. This is the future.